Okay, so essentially, I suppose fundamentally, I'm sure people have seen all of these screens previously, but it's why we all go to work, because we want to try and keep mums and babies safe. And you can see that over the last, so this starts back in 2010, there hasn't been significant changes to maternal deaths, and obviously every 3 years there are reports that focus on why mothers die during pregnancy and in the postnatal period, and each year we'll focus on a small number of things. And actually we're going to keep on bringing these up because I think it really reinforces the message about why what we're talking about today is so important. And you can see here, so this is looking at the last triennium, so the report that came out in 2023. You can see in that there were a number of deaths, so 33 women died in relation to COVID-19, but actually cardiac disease, so maternal medicine related, blood clots that Trudy has already talked about, epilepsy that Trudy has already mentioned about, actually these pre-existing cardiac problems absolutely make a difference, and that's why we need to try and recognise these women who are at risk very early in their pregnancy to ensure that they have the correct care. Okay, and you might think, well, actually I'm a midwife in the community, I'm not a specialist maternal midwife, but we all have a role to play in this. We all work as part of a multidisciplinary team. We all need to be able to recognise those flags about what is really important, and make sure that we are signposting people to the direct services very early on during their pregnancy. And we all can safety net and give advice and try and recognise where we are. And this is, I suppose, this is again one of the infographics from the last Embrace report, making sure that we understand where our role fits within the maternal medicine networks. So essentially there are now central hospitals with trusts that work around those hospitals, and they all feed in, and that's what Trudy was talking about, those ABC sort of streams of care. So what you're trying to establish is actually what does that woman need and where is the best place for her to be seen and at what time. And thinking about it from two prongs. So what we are thinking about is any woman who has a disease, so who is pregnant, actually pregnancy might have an effect on that disease process, okay, but also the disease might have an effect on the pregnancy. We need to think about it coming from both sides of the coin, okay, and often those two marry relatively well together. And this is just thinking about physiology, and we're going to break down each of these in turn over the next sort of half an hour or so, but I thought it was quite a nice slide to show you actually pregnancy affects every part of our body, okay? So from a respiratory point of view, it increases how much we are breathing in and out. It, from a heart point of view, our blood vessels dilate, our heart is working much harder, our kidneys have a much greater blood flow working through them, affects the way that drugs are processed. It affects the muscles, makes us more at risk of infection. We all know it affects hormones of lots of different types. It affects our gut. We've already talked about the risk of blood clots, the way that it affects our blood, and Trudy was talking about the blood becoming sticky and why that happens. But you can see that actually, and those changes, as Trudy said, happen really early on during the pregnancy. So what we're going to do is we're going to go through the different systems. We're going to look a little bit about normal physiology, but also what happens in pregnancy, okay, and why it's important. We're going to think about the things that if you are taking a history from any woman about what things are going to flag to make you think, actually, I'm really worried about this and I need to do something about it now. Trudy already really nicely highlighted that actually sometimes it is about picking up the phone when that woman is in front of you to say, actually, I'm really worried about X, Y, Z. Sometimes you can send her through a routine clinic, and that's absolutely fine, but it's about trying to pick up those women that need to be seen early on in their pregnancy. sometimes women are really good at giving a history and they tell you exactly what you need to know, or if they've written all of that information on their self-referral form. But actually sometimes it's a little bit vague, and just trying to think about what questions can you ask when that woman's in front of you to try and help elicit, actually, am I worried about this woman? Do I need to talk to someone now? Do I need to phone a friend? Actually, can I speak to someone next week? Can I put her through the normal pathway? Okay. And actually, I think this is not about you knowing all about maternal medicine in details. This is about asking the right questions to make sure that you are picking up those women at most risk and referring them through the right pathway. So I do more fetal medicine than maternal medicine, and when I first started, I was like, I'm never going to know what's abnormal and what I'm going to do with it. And actually what I have absolutely realized is, actually, I'm not a tertiary centre fetal medicine consultant, but I absolutely can recognize what's not normal. And actually that is just as important, to know that it's not normal, and I know that I need to do something about that. So don't come away from this thinking, oh my God, I've got so much I need to go away and learn. Actually, working out those red flags and recognizing what is a risk is actually what we want to try and support you all to be able to do. So first of all, we're going to talk about the heart, and I don't know why we always talk about the heart, but we do. And why is it an issue in pregnancy? So you can see here, so there's different colours. We're going to essentially ignore the bottom bits, okay? But this looks at your cardiac output. So how hard is your heart working during pregnancy, okay? Looks at your heart rate, so how quickly is your heart beating, and about the stroke volume. So as your heart contracts, how much blood is coming out of that heart in each pump. And you can see that the combination of your heart rate going up and each beat pumping out more blood means that your cardiac output, so how much work your heart is doing and how much, I suppose, volume you have within your circulation, increases significantly. So increases by 50% during pregnancy, but this is at 5 weeks. So you can see when you're booking women at 8 weeks, actually lots of those physiological changes have already happen, okay? And most of us can tolerate that significant increase in cardiac output relatively easily. Our women are young, they are fit, they are relatively healthy, and actually they can physiologically cope with those changes, okay? But there are absolutely women who, even very early in pregnancy, that increase in cardiac output is a significant risk to them, okay? And again, I can't list all of those necessarily off the top of my head, okay? I could give it a good go, but actually what you need to think about is which of those women are going to be most at risk and why, okay? And they are not always because of pre-existing congenital cardiac disease, okay? Women are now becoming more complex. We are generally less healthy, and that in itself has an impact on the women that we are seeing. So the question is fundamentally, can your heart increase its cardiac output safely? So just thinking about how does the heart beat, okay, and why is it a problem with some problems during pregnancy, okay? So essentially you have blood coming in to the top of the heart, okay, into the two atriums, okay? When the atrium contract, which is what systole means, the blood then flows down into the two bottom chambers, which are the pumping chambers, okay? Those ventricles contract and the blood comes back out, okay, up into the lungs or around the rest of the body, and then the ventricles relax, and that allows blood to come back in, okay? And you can imagine that actually if you have a problem with your heart, that means that the outflow, so what blood is able to get out of the heart, okay, is limited by either that the heart can't increase the way that it pumps enough, or that those blood vessels and those valves are narrowed. That's why there are a proportion of women that can't cope with those cardiovascular changes, even very, very early in pregnancy, okay? And this is actually what Trudy was talking about for heart disease. You can see the ABC, okay? And again, we are absolutely not wanting you to know about those different lists, okay? It's about thinking actually, why are these women in category C the women that we are most worried about, okay? It's because their heart can't pump properly. So their left ventricle, so the pumping chamber that pumps blood around the body, that is not working properly. So it can't cope with the increased demand on the heart to be able to cope with the increased fluid volumes. Aortic stenosis, so there's a narrowing of the big blood vessel coming out of the heart that sends blood around the body. It means that, again, it can't increase that cardiac output, okay? So lots of things, but again, it's a real, as Trudy said, it's a good source of information to work out who might need to be seen, okay? And just on the, Trudy was saying actually, or I think it was maybe Kat was saying just in the questions about most women will tell you, okay, we had a lady recently who booked with us and she had a big scar all the way down her chest. And it was a lovely summer's day, so it was last summer, and she had a V-neck top, and she said no one mentioned it, that I needed to go and see anyone. She's like, actually, I had this repaired as a child, and literally didn't think anything of it. So you hope that women will mention it, but they don't always, and that's when we have to ask the right questions. But what are those questions? So red flags are, wait a minute, essentially things that make us try and work out who's most at risk, okay? And these are cardiovascular things, but the problem is that they don't necessarily come in waving that red flag in front of you. So things that from a chest pain point of view that you might want to think about, actually, what type of pain relief do they have? Where is that pain going? Have they got other not very nice sounding symptoms? Are they ever coughing up any blood? For palpitations, who else in their family has might have any problems? Have they had previous surgery? Are they getting palpitations but also passing out with them? That's a really worrying thing, okay? And shortness of breath we're going to talk about in a little bit more detail in a minute. But really practical questions, because they don't come along and say, actually, I've got orthopnea, okay? And most people probably don't even know the word orthopnea or what it means, okay? But essentially it's, can you lie in bed flat at night, okay? So how many pillows do you normally sleep with at night, okay? And actually, inability to lie flat on a bed, okay, isn't, although we ask women to lie on their side, most women can lie on their side relatively flat, okay? The inability to lie like that for long periods of time is not normal in pregnancy, okay? Do you ever wake up feeling short of breath overnight? They're really practical things. How far can you walk? Actually, can you potter around the house okay? Can you walk down the road? How about when you climb a flight of stairs? Do you need to have a rest when you get to the top, okay? Palpitations is one of those words where it means different things to different people. Even as clinicians, I might interpret the word palpitation differently to one of my colleagues. So what I always do is ask them to tap out what they're feeling, okay? Because it's a really clear way of trying to get them to express what they are feeling. And it means that when you are talking to someone about it, you can explain exactly what the impact is on that individual woman. Is there any family history? Has she had any operations? Has she actually ever been told not to get pregnant? Okay, because that is a massive red flag that's going to absolutely want to make you pick up the phone. And just a little bit more about palpitations. So we have lots of women, don't we, who come through saying that they've got palpitations, so that awareness of a fast heartbeat, but actually that's often relatively normal. That thumping sensation can be an extra sort of what we call an ectopic beat, and if people have a warning symptoms before the palpitations, again, that can be relatively reassuring. But there are other things that make us worried, okay? We're not going to go through those in detail, but it's just worth thinking about the sort of things that might be helpful. The problem is that we don't know who has cardiac disease, okay? So out of this again is data from Embrace looking at the heart disease deaths in the last triennium, okay, but 74% of those women, so 3 out of 4 of them, okay, did not know that they had cardiac disease, okay. So it's our job to try and recognise those women who might be at risk, okay. Ischemic heart disease. So we always think about the older population having heart attacks related to diet, being overweight, smoking, diabetes. Actually, our pregnant women are now falling into that population sometimes, okay? I think as obstetricians and midwives, we worry about those women with significant pre-existing congenital disease, but actually that's, yes, it's really, really important, but we need to cast our net wider of thinking about what else might be going on. And again, that's just a little bit more about deaths from ischemia. So there were 20 deaths in the last triennium. And if we think about all of those risks, so we know that our pregnant women are getting older, that women are smoking, or that we're trying to reduce that as part of saving babies' lives. Women are more overweight, more and more women are have pre-existing diabetes, have pre-existing hypertension. So those risk factors actually aren't that uncommon for us anymore. And again, valve disease. So you can see here that mitral stenosis, so one of those valves is very narrowed and unable to cope with the increased circulation that is needed in pregnancy. But actually she didn't know about it. We have lots of women who come from abroad and have never had their heart listened to. So we just need to be really mindful of the fact that our pregnant women are becoming more and more complex, okay? So this is again a vignette about a lady, and she on post-mortem had severe rheumatic mitral valve disease. And again, this is about a mechanical valve. So a false valve, actually lots of these women are very, very aware that they need to go on to blood thinning treatment when they are pregnant, because the blood becomes more sticky and more likely to stick onto the mechanical valve. But we need to get that woman seen early, because actually they need high dose low molecular weight heparin, okay. And she knew that she was really, really high risk, but actually she didn't start on a high enough dose. And very sadly, she died because of clot that formed on that valve. Again, most of these women will know, but if someone comes to you and says, actually, this is what's going on, pick up the phone and ask. And again, breathlessness, it's really hard, isn't it? You have someone who's sitting in front of you saying that they're short of breath. Actually, is that just normal for pregnancy? Are they anemic? Have they got significant asthma? Is their heart function not working properly? And our job is to try and tease out what are those things that are most at risk, okay. Just looking at the physiology of your lungs and what happens during pregnancy, okay. So actually, luckily for us as obstetricians and midwives, there isn't any change in how quickly women breathe during pregnancy, okay? So really, really important. So if someone is breathing quickly, it's not just because they're pregnant, okay? We have to take it very, very seriously, okay? And there's also no change in your peak flow. So how quickly and hard you can breathe out. And again, that's really important for our women with asthma. And talking about asthma, your job as the midwife who is potentially booking that woman is to try and I suppose impose upon her and talk to her about her medication that she is taking is safe during pregnancy, okay. We treat asthma in pregnancy the same as anyone else outside of pregnancy, okay. The biggest risk to any mum during her pregnancy regarding asthma is that she stops taking her medication, okay. And you can see here from an American study, it's quite old now, so nearly 20 years old, okay. But actually women, because they want to do everything they can to try and keep their baby safe during pregnancy, women tend to reduce their medication use naturally just by themselves, so between 5 and 13 weeks. So if you're booking someone at that stage of pregnancy, even if they have well-controlled asthma, it's a really good place to say, actually, taking your medications is completely safe. And asthma is a little bit unpredictable during pregnancy. So a rule of thirds: third get better, third get worse, a third stay the same. Okay. But again, this is a woman within the embrace who died of asthma. And here, if we just look at this sentence, she was using her reliever inhaler 8 to 9 times a day and was advised to see her GP. But what does good control look like? And so I think just some questions to think about when you see those women at booking. Okay, so actually women who have well-controlled asthma shouldn't have generally any daytime symptoms. They're not waking up at night because they're short of breath. They're not having to take lots of their rescue medication. They've not had any recent attacks, and they don't have any limitations on exercise, but they don't come and tell you that. Okay, so things to think about: how often are they using their reliever inhaler? Are they like the lady in the vignette who's actually using her reliever inhaler 8 to 9 times a day? When did they last have any steroids? Do they keep rescue steroids at home? Have they ever been to the intensive care unit? And when was that? And they're all really practical questions that can help you to work out about this woman's asthma, and actually, can I send her through that routine clinic pathway to have a conversation, or do I need to do anything more urgently about that? VT, Trudy's already touched on this, but because it's so important. Okay, but this is looking at how sticky your blood becomes essentially over the course of a pregnancy. So the first dot is about when you're non-pregnant. The second dot is in your first trimester. So you can see right at the beginning, okay, there is an increase in how sticky your blood is. Okay, this is particularly in the third trimester. So this is third trimester, and this is up postpartum. Okay, but essentially your blood becomes more sticky. You have increase in clotting factors. We've talked about how much your blood volume increases. We've talked a little bit about the fact that your clotting cascade, so the proteins within your blood become more active, and that's why the blood becomes sticky. Okay, but also when you're pregnant, if you imagine you've got a big baby and womb which is pressing down onto those blood vessels, that again stops the blood flow from coming up to your legs, and it can all just be a little bit slower. Okay, we all have every set of notes, regardless of how you are booking women, be it on paper, on different digital tools. Every woman will have a risk assessment for VTE prophylaxis. And Trudy was talking about those women who've had a previous VTE, how important it is that they get really early antenatal prophylaxis. And that's not something to defer at all. Okay, so you think about other things that we think about risk factors for VTE. So if you've had a cesarean section, your risks and odds ratio is how much more likely are you with that risk for this thing to happen. Okay, so your cesarean section doubles your risk, twins doubles your risks, preeclampsia increases your risk by 3 times. Having had a previous venous thromboembolism increases your risks nearly 25 times. Okay, so that's absolutely huge. Okay, and that's why it's really important, because those blood clotting changes happen so early in pregnancy that we need to act on that really quickly. Okay, but also just keep on reassessing during pregnancy. And questions to ask. Trudy's already touched on these again. So because they might say, oh, I've had a clot. Actually, when was it diagnosed? How long did they have treatment for? Because again, sometimes people say that they've had a clot, but they say, oh, actually, I went to A&E, they gave me some treatment, and then I went home, and that was it. Actually, that woman's not had a blood clot, but try and find out a little bit more information. What treatment did they have? How long did they have it for? Who do they see? Where were they looked after? Anyone in their family ever had blood clots? So really practical things, and getting information from GPs, from the women, other hospitals is really important. And I suppose just for any of you who do work in triage, because although you might be a community midwife, lots of you will work in other services as well. Just to labour the point that not a PE is when someone comes in with chest pain or shortness of breath, that's not the diagnosis. Actually, we need to work a little bit harder to try and unpick what is causing that woman's symptoms. Okay. why do you become anemic during pregnancy? Actually, it's so common, but it's all to do with the physiology of pregnancy. Okay, so we've talked about that your plasma volume, so how much blood you have, essentially the volume of blood increases significantly during pregnancy. So we said up to 50%. Okay, but the amount of increase in your red cells only increases a much smaller amount. Okay, so therefore you can see in total the proportion of your red cells drops, and that's why women become anemic during pregnancy. So lots of the anemia we see is just physiological because of the normal changes that happen during pregnancy. Okay, but we know there are lots of other rarer causes of anemia. So iron deficiency, clearly super common, but also other nutritional problems, B12 deficiency, folate, hemoglobinopathy. So think about women that you are seeing and doing those family of origin questionnaires, and lots of other things. But again, can present with really vague symptoms. Are they tired, breathless, and pale? GI, what does the physiology of pregnancy do to our gut? So we have got a growing tummy. In due course, will displace the abdominal organs, and so make things, for example, like appendicitis much harder to detect. But much earlier in pregnancy, it's all of the effects of the hormones of progesterone. Okay, so you can get reflux, nausea and vomiting. Women often become really constipated, and it's a really common side effect of medication. Okay, and so lots of those are very common. Okay, but actually what we want to try and do is look at those red flags. Okay, which women are we really worried about? Okay, bowel cancer absolutely happens to women during pregnancy. So if someone says that they've got some bleeding, they've got unexplained change in their bowel habits, okay, if they've got diarrhea, they're going to the toilet 5 or 7 times a day, that's not normal. And just because they're pregnant, we shouldn't ignore those red flag symptoms. So really important that we address those. Kidneys, so we're talking about the increase in blood volume, and again there's a massive increase in blood that goes through the kidneys, and that affects what's called your glomerular filtration rate. So essentially how good are the kidneys at clearing stuff through the kidney. Okay, really important when it comes to drugs. Okay, but early in pregnancy, again, it's this progesterone hormone that can cause problems by causing the muscles to relax, and women are much more prone therefore to infections and so urinary tract infections and pyelonephritis. Also increases your chance of preterm birth, which I'm sure Austin will talk to you a little bit later on about. Okay, we all look at blood results. Okay, I don't know what anyone else's electronic system is, but they're not set for pregnant women. Okay, so you can see actually if you have a creatinine of 80, actually it's well within the normal range if you're not pregnant, but if you're pregnant, actually that is not normal. Okay, and so we just need to have a little think about, is what we are seeing normal? And that's not necessarily your jobs, but it's important just to have a little bit of knowledge about the changes because of the physiology of pregnancy, about what we are seeing. That urine dip right at the beginning of pregnancy is so important. So yes, looking for infection because of the risks of asymptomatic bacteria and preterm birth, but it can also give us a real key about other pre-existing kidney disease. So actually, has she got proteinuria at booking? Has she got 1 or 2 pluses of protein? Send her off for a PCR, because if she has got significant proteinuria, we talked about why that's so important from a VTE risk, to be able to have conversations with her about the risks during pregnancy of worsening kidney disease and the effects for the baby of having pre-existing renal disease. Has she got pre-existing diabetes? Sometimes absolutely that just presents itself with some glycosuria at the beginning of pregnancy. Or has she got some hematuria? Okay, looking through at some historic results can sometimes be really quickly, and think about, are there any medications that she's taking that might be affecting her kidneys? Headaches, super common, but can also be really serious. Okay, and it's a really hard job to try and tease out. Okay, about what is normal and what can be serious. Okay, red flags to think about. Okay, ask her to describe the headache. Okay, if it's sudden onset, okay, they often sort of will clap their hands like that, okay, or describe it as the worst headache ever. That is a really worrying thing, okay. Headaches that are persisting, not settling down with normal, with just some simple pain relief, other associated symptoms, or needing excessive opioids. So really good, strong painkillers that still aren't helping. Okay. So if anyone says to you that they've got headaches like that at your booking appointment, that's not something to refer down a normal send off an obstetric referral to get seen at 18 weeks, 25 weeks. Actually, that woman needs addressing now. And because of all of the, I suppose, those pre-existing, the things that we talked about with heart disease, women becoming less healthy, actually we do sometimes get women who present with strokes during pregnancy. Okay, so just because you're pregnant doesn't exclude all of the other things that you can get outside of pregnancy. So hopefully you've all heard of FAST, so facial weakness, arm weakness, speech problems, and call 999. Okay, and you might be the first person that woman tells about because it's just happened, and don't ignore that. And this is just about SUDEP, which Trudy mentioned again, okay. And it's essentially the effect of that increased blood flow through the kidneys that mean that the way that the lamotrigine is processed means that you can end up with levels of the drug which are no longer effective. We talked a little bit about medications in pregnancy, and Trudy mentioned UKTIS. So these are the two services. So the UKTIS, okay, which is more for healthcare professionals, and BUMPS, which is the patient information, and the two sites link very, very well. Okay, it might also just be worth knowing. So for UKTIS, if someone's on some weird and wonderful, we always get our trainees to call UKTIS because they're an amazing source of information. They have access to all of the American stuff as well. So definitely worth just knowing about, not necessarily for you to be calling them, but sometimes if you're next to someone and they go, oh, I don't really know about this, say, oh, actually, why don't you look on that? Okay, and you can see all of those effects on physiology about how they affect the medications. I'm sure Lila will talk about this later, but it can affect the absorption of the medication. It can affect how the medication is distributed around your body, how it's processed by the kidney, and how your kidneys work. So the physiology of pregnancy make a real difference to how our drugs work. And this is just again about SUDEP. So worrying things, women having nighttime seizures that aren't controlled, and their treatments becoming ineffective. All of those things increase the likelihood of sudden unexpected death in epilepsy. Okay, and that some of that is related to the physiology of how these drugs are processed. So it's why it's so important not to refer that woman through a normal pathway, but to pick up the phone and make sure that she's seen at an appropriate early time. And mental health, I think whenever you see a woman, okay, we just need to think about their mental health as well. Okay, you may be the first person that has asked those questions. Okay, we're in a really privileged position, and often women will tell us things that they've not told other people because they have that trust. Okay, and although it's not maternal medicine per se, I think any intervention that you have with a woman, you need to think about that. And if you look at these red flag symptoms at the bottom, so significant change in mental state or emergence of new symptoms, new thoughts of acts of violence or self-harm, it's really hard sometimes to tease that out of a woman. Okay, and I think sometimes we're all worried about asking women because we think it might seed that thought and that thought, and that we know that that's not the case. Okay, so just some really nice ways of asking questions in a supportive way. And fundamentally, we are a team. It is much better to ask. Okay, if you are not sure, okay, pick up the phone and ask someone. I think we would all prefer to be asked than have the woman that Trudy talked about embrace case vignettes that you think, oh, actually, if only things had been done differently. Okay, again, this was out of an embrace report. So the 3 Ps in a pod. Okay, so every other day a pregnant or recently pregnant woman dies in the UK. Okay, 2/3 of maternal morbidity is not due to is due to medical or mental health and not the pregnancy, and therefore it's okay to ask. We don't expect any of us to know everything, okay, but knowing what you don't know is just as important. And I suppose just think about that, the inequity of care, really, really important, that we don't lose that message. And there we go. It's a complete whistle-stop tour.
Thank you, Sian. I always love these presentations. There's a couple of questions that have come up. The first one is, what is the relevance of not being able to lie flat or using more pillows at night, or how does this affect the cardiovascular system?
So it's because as you are lying flat, essentially if you've got fluid on your lungs, so if the heart's not working properly to get all of that circulation around your body, you can get fluid that's building up in your lungs, and as you lie flat, essentially that fluid is stopping your lungs from working, so you're a little bit like drowning yourself. So it's a really, really important, really worrying thing.
Thank you. And then there's a question/comment. As a midwife has asked, women on low molecular weight heparin are often induced to arrange timing of the last dose. I found that a plan for how long it is safe to leave them without their heparin is not always made, and it's not always part of the management plan by a maternal medicine team. Do you have any guidance in this area? I recently had a woman with May-Turner syndrome who had a multiple DVT and PE in the past and didn't have a robust plan about how long she could be off the heparin, and didn't address the 48 hours of unsuccessful induction.
Yeah, and I think it's a really, really good point. We try to time those births, but we know that induction can take days. And so they're absolutely part of our birth plans. What we will often say, it's down to a senior decision making to say, look, we're going to start this pathway. We'll potentially, for example, if you're a prime, we'll give you an enoxaparin at the beginning of your induction process, and some more senior will review that before your next dose to make sure that that window doesn't become too long. And we have to keep on having those conversations because we can't make a birth plan that covers all eventualities. But it's really important that if you have a woman that is relevant to, that you ask, actually say, I'm worried that this woman is at significant risk of a VTE. We're now 48 hours without any. She's not about to have a baby. Maybe we should think about having some enoxaparin. And that's where that team working comes in, because someone else might not have thought of that. But we try to address it in our birth plans, but because induction of labour is so unpredictable, we have to keep on thinking and reviewing that plan as the induction progresses.
Great. Yeah, no, where I am at St George's, we work very closely with the haematology team, and I have to say the haematology registrars are great. Even if it's like 3 o'clock on a Sunday morning, there will be a haematology registrar on a bleep, and if you have questions like this, they're really helpful. And our haematology consultant generally has plans in place for these kind of eventualities, but if for some reason it's not there, you can bleep the haematology registrars. They are brilliant for these kind of things. And just kind of on a personal note, just what you were saying about checking with women if women give you medical terms, I've noticed with myself that, we don't always question them. We often just assume that because they're using a medical term that they're using it correctly. Palpitations is a big one for this. We recently, a while ago, we had a woman who told her consultant that she was having palpitations every night and waking up with them. And it turned out that what was happening is just when she was lying on her side, she could hear her pulse in her ear. And that's what she was calling a palpitation. And similarly, I'll out myself. We had a woman recently who had a history of intracranial hypertension, but had been in remission for 3 years because she'd lost a lot of weight. And she'd seen a neurologist earlier in the pregnancy who had said that she was suitable for routine antenatal care. And then she called up to say that she had significant tinnitus and that she was really concerned that because of the extra weight of the pregnancy, that her intracranial hypertension had returned and the tinnitus was a symptom of this. So luckily we had a neurology appointment in our joint neurology obstetric clinic later that week. So I booked her in, didn't ask any questions because she was a middle-class white woman, English first language, very well educated. Didn't occur to me for a minute that when she said, I've got this new onset of significant tinnitus, that it might be anything else. And when she went to the neurology appointment, when she was actually asked what she was experiencing, it turned out it was also just that when she laid on her side, she could hear her pulse and she could hear that whooshing noise in her ears. And then I felt really silly.
Exactly. I think it's just unpicking those, like people don't necessarily come and tell you exactly what you need to know. Like it's so like diarrhea is another one, isn't it? Actually, it means a whole host of different things to different people.
Yes. So yeah, and not being afraid, you just like now I just say to people, you know, people aren't afraid. People often use words wrongly, and I'm not saying you're using it wrongly, but I just want to check.
Yeah, absolutely.
Perfect. I'm just going to check if there's any more questions. Oh, actually, this is a good question. High platelets in pregnancy. What they're asking if you need to start anticoagulation with high plates in pregnancy, but also if you just do booking bloods and the platelets come back at 500, what's the significance of that and what's the pathway we should follow?
So we would always repeat them in the first instance. Sometimes it can just be related to the changes sort of in early pregnancy, if people haven't been very well. It's generally, so yes, there are a few women who have very, very high platelets who will need to go on anticoagulation. There is also just normal variation. So it's about looking at what that trend is and again, phoning a friend. I think there's no hard and fast rules.
Perfect. That's it with the questions. Thank you, Sian.
Thanks, Kat.
No problem.